before we discuss about the operative management of phalangeal base fractures, I think we need to just revise our knowledge about the conservative treatment. That any phalangeal base fracture, we should consider non-operative treatment if there is no rotational malalignment. And when you move the joint adjacent to the fracture, like metacarpophalangeal joint, we should look for any displacement, and there should be no subluxation or a dislocation. And once you reduce these fractures, they have to be stable. Then only you consider non-operative treatment. And these are the commonest way that we treat, like below elbow slab in functional position and a body strapping. But whenever you are treating any fracture non-operatively, they need serial clinical examination and serial x-rays once in a week or once in 10 days to look for displacement at the fracture site. These are the most common methods of fixation of phalangeal base fractures. So, a case of a badly displaced extra-articular phalangeal base fracture, there are many ways to treat this, and these fractures are very unstable. So, even if you achieve reduction, to maintain reduction in a slab or a ball bandage is very difficult. So, this is one method of fixation by putting a intramedullary bouquet technique wire. You see, if you see the fracture has been made stable and the metacarpophalangeal joint flexion has been achieved, and this is the result. Then I would like to explain or revise our steps of doing K-wiring for such fractures. First of all, by traction manipulation, you reduce the fracture, get it in aligned, and once you align the fracture, for little finger, you try putting first wire from the ulnar aspect of the finger because it is very easy, and confirm the advancement of the wire crossing the fracture site and in the lateral view into the intramedullary canal. Then you put the second wire and confirm the fracture that it has crossed the fracture site and into the intramedullary wire, and this is how we confirm on the X-ray. Now, sometimes the phalangeal base fractures are intra-articular. You see there is almost 50% involvement of the articular surface. So, even if you allow the flexion at metacarpophalangeal joint, the fracture will be displaced. So, these fractures need absolute stability for early mobilization. So, dorsal approach, by splitting the extensor tendon, we fix these fractures with screws. Another method of fixation that I would like to show in a phalangeal base fracture. Now, this fracture has too much comminution on the dorsal ulnar aspect apart from extra-articular fracture. So, this is so these are unstable fracture. So, one of the method of fixing this fracture is by putting a wire by bouquet technique. So, this wire has been passed from the distal end. So, first you make a drill hole with 1.5 or 1.2 mm wire and cut the tip of the wire and advance it. One wire is sufficient to maintain the reduction and alignment at the fracture site, and this is the function that you achieve. Look at the scar or entry point of the wire. Sometime you get multiple fracture. So, this is the fracture I want to highlight about the proximal phalanx base. Though this is undisplaced or not much displaced fracture and there is no angulation also, but the shaft fracture is potentially unstable. So, I have fixed the shaft fracture with the plate and so the phalangeal base fracture with the cross K wiring. So, at 2 weeks also we can start some mobilization if you fix both the fractures well. So, if you see, there are even sutures were not removed and we can start the mobilization, and this is the 9 weeks follow. They usually get a good function. So, multiple phalangeal base fractures, these fractures needs fixation because if you see the angulation at the fracture site on the lateral view, they are difficult. If you don't treat them well, they'll end up in a clawing deformity and the knuckle prominence is not seen, so the reduction of the grip is seen. So, these fractures this is one way to fix the fracture by close reduction and K wiring. Similar fracture, and because of the swelling, and there are other method of fixation that if the fractures are at too much base, then we can consider them fixing with Jess fixator. And if you see, this fixator has been applied in such a way that no wires are put in the fracture site and early mobilization can be done. Last and most important, please be careful about the pathological fractures and reflex sympathetic dystrophy in treating phalangeal fractures. Thank you so much.